for us, they should be the exception, not the rule, actually. And I think the longer we continue to need to rely on patient access schemes means we've still not fixed and understood the problem. And I think whatever we think about today, we have to future-proof it. It always seems to me we're 5 or 10 years behind on our solutions. And you've got to think about what's happening globally. There's a huge downward pressure on price everywhere, even in the US.
Well, I wouldn't say we like them, but I think we recognise that they have a place for some medicines. But I think to the point about the UK, we have a set of sort of published list prices in the UK, which more often don't reflect the actual costs that the NHS pays. And I think we'd probably like to move more towards a model where there's a pricing discussion at a national level, in parallel perhaps with the conversation with NICE, and then we cut out what is currently enormous duplication of negotiation throughout the system, which I think has created a system where it's just not, pricing isn't opaque at all.
I think the NHS would just prefer the list price to be lower and keep it simple and not have rebate schemes or other complex things, but define what that right value is.
This is the real issues that we constantly hear, that creativity cannot be supported by the NHS. Patient access schemes, the biggest moan ever, comes from the NHS saying, oh, don't come with a patient access scheme because we couldn't handle the administrative burden of it. I think that's the wrong approach. You should be accommodating, not you personally, but the NHS should be accommodating creativity. And yes, it will be more work, but you should be valued for that work. And don't rely on NICE and the interaction between NICE and industry to only solve the issue through a cost per quality debate. And I think the AAR will show that that actually isn't where the debate will go. It will go to you, to the NHS, where it has to happen.